So just to thank those participants who've joined us here today, and just to give you some background to the conference, which I started during the COVID years with my own residents, and we were able to scan slides and discuss them virtually. And Ranjan suggested that we join this platform and have a wider audience join us. So we'll try it out and see how this goes. And the way I like to conduct these conferences is that I put on a slide, as you see here, a scan slide. I will give you the history, and then give you the opportunity to tell me what you think. And then the conversation and the differential diagnosis can go from there. And any questions or comments that you have, you just, I think Emily's or Charlie has got you covered on that to give you the opportunity to speak and interact. So it is an interactive conference. So, feel free to unmute yourself and fire away. So let's start with this. This is the first case I chose for you today, which is a 57-year-old female. And you can all recognize that this is bowel mucosa, colon mucosa. And just to go back to low power, you can see a tumor literally occupying the submucosa and the musculatus propria all the way up to the serosa. And I'm hoping you can see my arrow, which outlines the tumor itself. And there's a section of that. The epicenter seems to be somewhere between the submucosa and the musculatus propria. So we'll assume that it's in that area. And what I want to do now is go down on a higher power in order to give you a chance to look at the cytomorphology and the patterns. And you can see these. I try not to give you too much of a description leading towards the diagnosis, but I'll try to help you appreciate the morphology. You can see these trabecular cords and bars of cells, and I'm going to show you the collagen in between these areas. Go down on higher power. These are not glandular structures. These are artifactually separated. So just to get that aspect out, that you're not thinking it's epithelial, just to help you along with that component. These are not glandular structures. They're just trabecular architectural arrangement of these tumor cells. And if we go down anywhere, they're pretty similar wherever we go. You can see these large tumor cells. They do look sort of columnar, but like I said, these are not epithelial, just to help you along with that. Large nuclei, and this is about as close as we can get to it. Vesicular chromatin, some of them having a nucleoli. And again, that's a nest, and this is a trabecular component, which I've already mentioned. Now, that's pretty much the architecture and pattern as we extend all the way through into the musculatus propria, where you can probably see more solid trabecular pattern. Like I was saying, it was artifactually arranged in the submucosa. Here, just probably a better variation to these larger trabecular bars. You can see these cords and nests here. Okay, just to give you a high power. And that's pretty much the arrangement in cytomorphology. And at this point, I'd like to invite participants to tell me what they think, and any differential and or any investigative markers that you'd like. If we start off with differentials, we can begin a conversation on that line and go from there. Any thoughts? I'm hoping that you can hear me.
I have
Yes,
one raised hand there, Coom, I think. Sorry, this is just Emily speaking. I think we had a raised hand. If you'd like to unmute yourself, please feel free to do so.
You have somebody who's speaking there. I cannot hear them. No, I don't hear anything, Emily or Charlie.
Sorry, Koom, we can hear you. I'd just like to invite the participants to unmute themselves if they'd like to engage, just to make this session interactive, or else if you'd prefer to type into the Q&A box, please feel free to do that and I can read out the questions.
I think maybe you need to nudge people along then, Koom.
Okay, let's perhaps start with getting the epithelial component out of the way. And like I said, it is not epithelial. And if you chose to do the epithelial markers, then both keratin, whichever you choose, whether it's a cocktail. My favorite is AE1, AE3. Some people prefer the CAM 5.2. Which is a low molecular weight, and others prefer pan-cytokeratin, which is MNF116. Those are all negative, so conclusively not epithelial, just to get that out of the way. In my approach to tumors that I'm unsure of the diagnosis, I like to rule out melanocytic. And I embark on a small screening panel of melanocytic markers. Even though S100 and SOX10 are not truly melanocytic, they encompass the nerve sheath tumors as well. That's my second stop. And then thirdly, of course, in context, if we're thinking about mesothelioma, or in context, if we're thinking mesenchymal, I would then embark on a set of immunohistochemical panels for those possibilities. In this context, I do not think anybody's thinking lymphoma, so I can take it that we will not be doing any lymphoma markers.
Koom,
yes.
Sorry, Koom, we've got some comments.
Good.
Emily, sorry, they don't have the ability to unmute, so they'll have to type in, okay? So yes, Tom says he'll start with a nested epithelioid neoplasm consideration for a GNET or epithelioid gist or neuroendocrine. Someone else has, Dina has suggested alveolar rhabdomyosarcoma. So those are the suggestions we've got thus far.
Okay, wonderful. That's a great start. That's a great start. So having ruled out epithelial, and I've got some, that's an excellent differential diagnosis there. The neuroendocrine, the GNET, and the GIST. So let's get GIST being the most common and neuroendocrine out of the way. The neuroendocrine markers are negative. My approach is also, like most of you, to do all of the available neuroendocrine markers. I like to do synaptophysin, chromogranin, as well as the new INSM1. I like all three. Chromogranin, for me, plays the most important role in identifying neuroendocrine tumors, even though it's very focal. Sensitivity is not as great as synaptophysin, which has a much better sensitivity. And even ISM1, which is a nuclear marker, does stain up non-neuroendocrine tumors. So all three, I think, are important in order to rule that out. I can safely say all three were negative in this case. So we can get the neuroendocrine tumors out of the way. That is a distinct consideration in regard to contextual bowel wall tumors. Just, of course, epithelioid just has to be in the differential diagnosis. Remember that apart from DOG1 and c-KIT, which we traditionally use, you may also be thinking about outside of the routine or the most common molecular just being KIT or KIT mutated. Think about PDGFR. That's and if you have that antibody for PDGFR, that's useful to identify that as well. Or you can resort to molecular markers. All of the GIST markers that we have were negative in this context. Don't forget SDH, because SDH deficiency, but those are usually CD117 and DOG1 positive as well. But those are also consideration. The GNET consideration is an excellent one. And I mentioned in my second profile, immunoprofile, that I also like to resort to melanocytic markers with S100 and SOX10 being positive. So this in fact is diffusely positive for S100 and SOX10. And that does bring in another differential in respect to this. Any thoughts on that? What other differential would you bring in besides GNET with a diffuse S100 and SOX10?
Yeah, clear cell sarcoma.
Yeah, clear cell sarcoma, yes, is the bowel counterpart. The GNET is the bowel counterpart for clear cell sarcoma, correct? And the other consideration, given the morphology with these epithelioid cells, would be an epithelioid MPNST, epithelioid malignant peripheral nerve sheath tumor. Now, a subset of those are deficient for INI1, which is SMARC B1, and that was intact in this case. So to come back to your clear cell sarcoma, as well as the previous speaker who suggested GNET, we would then resort to molecular confirmation. And in this instance, we used FISH to probe for EWSR1, and that was rearranged. So you're spot on. Yes, GNET, and we do use malignant gastrointestinal neuroendocrine tumor, neuroectodermal tumor for the clear cell counterpart in the bowel wall. And these are well recognized, as you know, as a distinctly different from the soft tissue in that they do not express the true melanocytic markers, but they are positive for S100 and SOX10. So that's the way but the molecular profile, given the family of FET, which is EWSR1 and FUS, as well as the Krebs family. And the Krebs family, as you know, includes Krebs1 and ATF. So any of those combinations with the FET and the Krebs would help you in this regard. And we probed just for the FISH with one probe with EWSR1. We did not go for the partner, which would require sequencing in order to determine the partner on a fusion profile. So we call this, yes, we did call this a malignant GNET. Okay, any questions or comments on that? Anybody? So just a comment that came to mind whilst we're talking about GNET, what's been recently described is also extra gastrointestinal GNETs. Now that takes you to another level, because your first question would be, well, how different is that? So these are tumors occurring in soft tissue, but have the immunoprofile and molecular signature of GNETs. And how do you distinguish that tumor, because it's outside the gut, from a clear cell sarcoma? And the answer is quite simple, because we did explore that. The melanocytic markers are negative. It's an immunoprofile distinction, because the molecular signature is the same as clear cell sarcoma. And again, it may be Krebs or ATF as the fusion partner to EWSR1, but you would have to use your melanocytic markers to. There's a series that Dr. Fulp published, I want to say about 2-3 years ago. My timing is out, so I cannot recall the years. But if you went to Fulp Modern Pathology extra intestinal GNETs, that paper would come up, and that would give you. It's also got a very nice differential and covers all the FET Krebs groups of tumors, which when I last checked is now about 8 tumors that fall into the category. Any questions or comments? Everybody's quiet today.
If I may just comment.
Yes, please, Ranjan, please.
Taking advantage of my position. We had a case which was disseminated. This was about 7 or 8 years ago, and it manifested in the gynae tract. And of course, we were going down various avenues trying to elucidate it, not thinking of a GNET in that particular location. And it was only after a metastasis or potentially a primary appeared in the stomach that it sort of the penny dropped for us. So whether it was there originally in the gastric as a primary and then disseminated and presented with the metastasis. So it was quite an unusual case with a very similar translocation as you've described.
Nice. Yeah, that's interesting. Really interesting. Weird site to metastasize to, but
yeah, it was in the abdomen, around the uterus, in the wall of the uterus. So it was pretty much the abdomen pelvis.
And it was primarily GNET.
Yes. I mean, it was identical when the gastric lesion manifested itself.
Okay. Thank you, Ranjan. It makes me feel human here to hear another voice.
Yeah, no, I think the microphone has been disabled according to Zubair, so they can't unmute themselves, unfortunately. So we'll have to get, Emily's going to pick up the questions. I have a meeting to jump to. So please go ahead.
I think the microphones are working now. I enable for all attendees, so people can feel free to unmute or use the Q&A option, and I'll read them out.
Perfect.
Thank you, Charlie. Thank you, Ranjan. Okay, so perhaps we can move on to the next one where we can have people speak to me, which I really truly enjoy. Otherwise, I feel like I'm talking to a computer. Let's try this this example here. This is again, I'm trying to get you a history on this. Is a 65-year-old male, and this is a buttock mass in the buttock. And again, low power, just to get the lay of the land to you. You can see the epidermis, and there's this blue tumor sitting in the junction between the epidermis and the subcutaneous fat, with the bulk of it really pushing into the fat. So it's very well circumscribed. There is a second nodule there as well, and it may very well be the same nodule, but it doesn't matter. Just for purposes of our conversation, it is well described. You can see these vascular spaces here, okay? And some of you may like to call these staghorn vasculature, which is a useful feature that helps one determine that it's neoplastic staghorn vasculature, or the old term being hemangiopericytomatous vessels. So let's then go and look at the tumor itself, and any of these vessels I'll try and hone in on and show you the tumor cells around these vessels. And again, I'll describe these for you. Fairly uniform looking cells with pink cytoplasm. Some of them do have nucleoli, and the cytoplasmic borders fairly distinct, very clearly distinct. And
looks like glomus.
Yes, it is glomus. Correct, it is, and that's a morphological diagnosis, because there aren't many immunostains to help you in this regard, except for actin, which stains that. So it's a pure morphological diagnosis. And the question is, why am I showing you this? And the reason is that if you look around, and I'm trying to find areas, there is some evidence of atypia. Here I'm showing you these areas where the nuclei look larger. There's some coarse chromatin, and you can also see they're hyperchromatic. So when you drive around, you do see these areas. There's a few mitotic figures. There's no necrosis. The tumor is well circumscribed, and there's no infiltration. Here's a nice arrangement of a typical glomus for the younger residents who are online, just to show them the arrangement of the glomoid cells around vessels. But this does have atypia in it, which in my mind takes it out of the benign category of a benign glomus, which then brings in the question, well, when do you call a glomus tumor malignant? Again, I'm going to refer you to a paper which again comes from Andrew Fulp, Modern Pathology, and I think it was in the early teens, early 2012, 2014. Again, I think it was Modern Path, and he goes into the criteria for malignant glomus tumor, which involves a combination of size, atypia, mitoses, necrosis, infiltration, as well as depth. Those that are deeper would be counted as being contributing to the risk criteria. So this did not have all of those criteria. They had atypia and some mitotic activity. There was no necrosis, no infiltration that we could see of the soft tissue around. So we call this an atypical glomus tumor, for want of a better term. To my knowledge, it has not recurred. And that's the reason for showing you this, just to bring up the conversation about when is a glomus tumor malignant. We see many of these in the skin of the digits, the fingers and toes. Some of them are in the proximal arms and legs. This one was in the buttock, and this is what we called it. It was shown to me by my colleague in dermatopathology, George Shu, and that's what we agreed to call it, an atypical glomus tumor. Any questions on that? Comments?
Dr. Cooper, will you do BRAF on these? Because some of these, which may look atypical and infiltrative, could be malignant tumors. And it has been shown that some of these malignant tumors glomus can have BRAF.
Okay, that's interesting. No, we did not. I don't think we had BRAF at that time. Okay. But also the glomus tumors. What's the molecular signature? Is it a notched?
Notch. Yeah,
notched. Yeah, notched. So you say when it acquires BRAF is an indication of malignancy.
So, I mean, there's not many, but there are a few cases of malignancy.
Okay.
Because this is an infiltrative tumor, right? I mean,
right.
It looks on its own as, Sankops, right? But
yeah.
And the Ki-67 was within
was not very high. It was about 15-20%. Was not high. But everything's been excised, and I think the patient's going to do well, because I don't think there was anything for metastatic potential in this case. So atypical glomus tumors, so that they would follow up and watch. Thank you, Dr. Z. Any other questions or comments? All right, let's go to this case. It's another interesting case that I got a few years ago. These are mainly from 2021, 22. So they're already 3, 4, 5 years old. I'm starting with this one, which is a neck mass. The patient is 32. He's a young male, and the mass is about 10 centimeters. And here you can see it's fairly well circumscribed. But even at this low power, which I like, I always love these low powers on these scan slides, you can see this lobulated areas. There's large lobules, and within the lobules, there's smaller lobules. And I'll show you that just to get the architecture nicely outlined. But there's also central necrosis in some of these lobules, hemorrhage and necrosis. So let's go and look at the cytomorphology. Like I said, well circumscribed, almost a pseudo capsule to this. And here you can see, let's start here and look at the cytomorphology, which is pretty similar all over. It's a diffuse pattern. And you can see these nuclei. Okay, and you can see that they pretty much pleomorphic, the larger ones and smaller ones, very prominent nucleoli. Chromatin is vesicular. And I'm going to show you the cytoplasm here is sort of amphiphilic to clear and even vacuolated in parts. Here next door, which is where I did not want to start, is that the cytoplasm does look clear. So there is some clearing of the cytoplasm here, just to take you to these nuclei. And before I invite you to give your thoughts, I just want to show you a few other areas. Here's more necrosis, definite tumor necrosis. And here again, just to show you the mild pleomorphism in these nuclei. There's some areas where the atypia was much, much more obvious. I think that's an unusual atypical mitotic figure. But again, well circumscribed, lobulated, 30-year-old man, 10 centimeter mass in his neck. That looks a little spindle, but that was very few cells that was spindle. Most of them look round. Most of them had these large nuclei with nuclear pleomorphism. And you can see some of them appearing clear as well. Okay, any thoughts?
Ewing?
Ewing's has to be the first thought because of the round cell, the age, it's soft tissue, and clearing would also make you think of Ewing's, because in the old days we used to use a PAS-D for glycogen in Ewing's. I don't think many people do that these days, but Ewing's would be in the differential, and you can use CD99 to good effect in that regard. And in Ewing, CD99 is diffusely positive, but remember, it has to be a membrane marker. So it has to be diffusely membrane positive. And that's when, you know, you're really thinking, okay, this is going to be a Ewing's, and you're going to resort to molecular confirmation with, again, using the FET meaning the family of Ewing's and FUS, with the ETS family, which is Fly1, and rarely ERG. ERG is only about 5%. So I'm glad you mentioned Ewing's. It's a very good thought. The point I wanted to make about Ewing's is that these nuclei in some areas where they show pleomorphism is not a feature of Ewing's. Ewing's is very uniform, very round. The chromatin's fine, and these look a little too large. And I was looking for nuclei that looked more pleomorphic, just to help that process along. But some of the other tumors that I've seen with this particular group have shown more pleomorphism. So Ewing's has to be that. Let me hasten to add that the CD99 in this case was variable, patchy, variable, not something that engenders a good sort of feeling for Ewing's. So it was not the diffuse CD99. Okay, and jumping into Ewing's, I should add again, just for the younger residents who are on, that one has to rule out all of the other differentials before going to mesenchymal, and you know, epithelial, melanoma has to come into that, and even lymphoma in not necessarily in this context, but you may want to consider that as well. So we are speaking about mesenchymal tumors, and I accepted Ewing's given that epithelial and melanocytic have been ruled out. Any other thoughts?
Dr. Cooper, did you do WT1 on this?
Yes, WT1 is a great stain. Now, I'm so glad you mentioned that, because WT1 for this particular tumor, remember, we have to go back to our biochemistry. There are two WT1s. There's one that's raised against the N-terminal part of the protein, and the other is raised against the C-terminal part of the protein. Now, the antibody to the C-terminal, which most of us don't have, we're fortunate because our sister hospital has it, and that's the Children's Hospital, CHOP. They have the antibody to the C protein, which is positive in desmoplastic small round blue cell tumors. That's the only time we use the antibody to C protein to confirm that diagnosis. All the others, mesothelioma, serous carcinoma, etc., all use the N-terminal. This tumor also uses the N-terminal. So this is beautifully diffusely positive for WT1, which is a useful adjunct marker, but again, you still need to resort to molecular profile. Anybody want to guess what this turned out to be? I'm just curious. It's a tough one. It's very difficult, and you do not have to feel bad talking to me, because I do not take notes or note your name. I see Anna Budina is here. She was one of the earliest people who encouraged me to start this virtual conference in 2020 when COVID struck. So Anna is now at Camden Cooper, across the river from Philadelphia. Any thoughts? Anybody want to guess what this turned out to be, the molecular profile? Just
kind of reminds me of this. Jason Harnick did a couple of these.
Yep.
Showed the USCAP, and these were the CIC rearranged type of clear cell
correct.
sarcomas. And
Correct.
he showed a case in a head and neck. So,
correct.
So that's the thought.
Yeah, that's exactly what it is. And that's why I was placing the emphasis on morphology, because when you see a few of these, you begin to pick them up and predict that they're going to be the sick ducts, CIC, the fusion gene being DUX4. So Ewing's does come to mind. And then when you see this nuclear pleomorphism in here, I went to show you these large nuclei here coming up here, which is useful. They tend to have this clearing, but not all of them do. And that's also, I've seen about 4 or 5 of these. I remember one in the thigh, which looked pretty much more a round cell and blue, but did have nuclear pleomorphism as well. So you have to sequence these and determine. You can use fish as well. There are some problems with fish because they can sometimes be very close. The genes can be close and you cannot separate them. But fish is a good start. We have an excellent fish expert in our department, Dr. Zhang, who helps us with this. So they picked up one at fish a few weeks ago. So fish does help. And if that doesn't, you're still concerned about, then sequence it. Okay. Any other questions or comments? So let's go back to the suggestion of Ewing's, and that's a good sort of starting point, because we all recognize Ewing's, we all know the molecular profile and the immunoprofile and the distribution of these tumors. But then some years ago, about 8 to 10 years ago, they began to recognize tumors that did not have the FET ETS fusion partners, and this was one of them. This was the sick ducts, but at that point, they were not characterized with the molecular sequencing, and they called them atypical Ewing's. So at that point, they said they did not have EWSR1, and they used to use atypical Ewing's. And the second tumor that was also in that, or should I say third, also an atypical Ewing's, was turned out to be eventually the B core rearranged sarcomas. So that's where the atypical Ewing's has now fallen away, and we use the undifferentiated sick ducts rearranged undifferentiated sarcomas, or round cell sarcomas with sick ducts, or B core round cell sarcomas. Remember, B core also has other molecular signatures besides translocation. It can also have a mutation, and as well as the ITDs, the internal tandem duplication. So you have to sequence those if fusion's negative on fish or in situ hybridization. So that's where that's emerged, and we now recognize these as well. Okay, so that's the so-called atypical Ewing's. I'm not going into the so those the non-ETS or the non-FET. That's another conversation, another discussion. But that's a starting point just to understand where these atypical Ewing's are now characterized. Any other questions or comments?
Señorita Sarita, buenas tardes. Le saluda el doctor Espinosa.
Nope, sorry, I cannot hear you.
Quería pedirle un gas, porfa. Girón Tacna 678.
Can somebody translate that for us? No. Okay.
Hey, doctor, could you please repeat the diagnosis? It was B core round cell sarcoma, or it was a typical Ewing?
So it is an atypical Ewing's, which has been characterized as a sick duct, CIC. That's one gene which fuses with the other sick ducts, DUX4. So it's a sick ducts round cell rearranged sarcoma. Got it?
Okay, thank you so much. Thank you.
Okay, okay. So if there aren't any other questions, we can move on. Let's take another tumor. Let's take another 36510. Let's try this one. Okay, earlier Ranjan talked about a tumor in the uterus. I just want to share this one with you. And this is, as you can see, a needle core biopsy of a uterine mass. This is a patient is 53 years old, woman with a pelvic mass. And clinically, again, uterine tumor. And this is the needle core of the tumor. So it was a large mass, and they were able to get a needle core on ultrasound. Let me show you the morphology. You can see the pattern again, some nests and cords of these cells with a hyalinized stroma. Okay, small round cells. Again, cytoplasm looks a little clear. There's a lot of this crush artifact here, which gives you this false crowding of cells. But let's go to one of these areas where you can see better morphology, fairly uniform looking nuclei. And here again, the cords and nests. Again, I think this is artifactual here, this loosely cohesed cells, just artifactual. I think the key feature would be, again, cords and nests with the hyalinized stroma. Okay, before I go to any immunos, or anybody have any thoughts or a differential? Uterus 53. Is anybody on the chat, Charlie?
We have one. We have PICOMA was typed in.
Anything else?
That's everything that we have in the chat for now.
Okay, so we have PICOMA. I think Charlie has given us on the chat on this tumor. So the approach generally that I use on these, and I like to rule out leiomyosarcoma as a start. I like to, because you can get epithelioid leiomyosarcomas or epithelioid smooth muscle tumors, really. And again, my favorite 3 stains would be a actin desmin and a cal desmin. I like to use cal desmin in the uterus, the high molecular myosin chain for the uterus, because it's useful in distinguishing from endometrial stromal sarcomas. So then I would then embark on, in this case, the actin was positive, it was diffuse, but the desmin and the cal desmin were negative. So actin was positive. I'll submit that to the discussion and conversation. The suggestion of PICOMA is an excellent one. And before I usually get to PICOMA, I always ask myself, what else could this be? And other tumors that do come to mind would be the uterine tumor of the ovarian sex cord-like features. That's another tumor that has to be given consideration. The cords and nests is a good feature of that. They can be sheet-like. They can even form glandular. And for that, you need epithelial, mesenchymal, as well as sex cord markers to be positive. And the other, although not in this differential, the other tumor that I also give thought to is inflammatory myofibroblastic tumor, which I did not give consideration here because the cells are more round. There's no inflammatory component to that. And given that we ruled out, smooth muscle tumor with negative cal desmin, and more importantly, negative cal desmin with positive actin, you're correct, the melanocytic markers did come up positive. So this in fact is a PICOMA, and the current, so it had melin A, patchy, focal, and some HMB45 as well. And the current approach would be to give some form of risk stratification. How is this PICOMA going to behave? Is it going to be benign, or is it one of the intermediate categories, or malignant? And for that, again, I would refer you to the paper from the Harvard group looking at the criteria, which is size, age, mitosis, necrosis, and infiltration. And I always refer my residents and trainees to that. It's now in the WHO as well. And on a needle core, try to give some idea of where the risk stratification would be. And then the resection came out was a PICOMA, but even though there are no mitotic figures here, no necrosis, this did behave badly because it metastasized as well. So the follow-up was that it did metastasize to bone a year or 2 later. Any comments or questions? PICOMA of the uterus. Again, these are recent in the last 10 years or so, where we now recognize these mesenchymal tumors in the uterus. In the past, most of them were leiomyosarcomas, but those have become dissected now into a whole range of low-grade and high-grade uterine stromal sarcomas, as well as these other tumors which I mentioned, PCOMA, inflammatory myofibroblastic tumor. And then always don't forget UTROS. UTROS is always something that has such a heterogeneous morphology that you can sometimes misplace them. So always, you know, I like doing, and the way I do it is I think about mesenchymal markers, that's actin and desmin, and then epithelial, keratin, usual favorite keratins, and then sex cord stromal, which is steroidogenic factor 1 and inhibin. Those are my markers I like to use for the UTROS. And again, those have also been risk stratified recently, again, also from the Boston group. They can be given to Dr. Young's paper, I think, and some of them do behave in a malignant fashion because we always thought that they were benign. So, you know, refer to those papers when you're confronted with a UTROS. Any questions or comments?
Dr. Cooper, so all the other differentials you mentioned, will you see such a consistent arrangement of the cells, the clearoid change and the stroma, and the vessels? Will they have same arrangements? Because this is very consistent from field to field. That's
very true. That's correct. This is not the classic morphology architecture for PCOMA. The classic is more sort of diffuse sheets. They're usually epithelioid, and they can be fascicular or spindled. They do have a nice, unique arrangement around vessels, which this one does not show. But when you go back in the literature, there was a series described by Dr. Fletcher in the retroperitoneum that had hyalinizing stroma. And I think this fits in with that, with this trabecular cords of tumor cells with this hyalinizing stroma. And to me, this is very much like that described in AJSP about 12, 15 years ago by Dr. Fletcher, retroperitoneal hyalinizing sclerosing PCOMAs. So I think that fits, and you're quite right. This is not the classic architecture. You have to think about it and then do the stains. And that's why going through the differential that we talked about is useful to approach these. Is it mesenchymal? Is it smooth muscle? Is it endometrial stromal? And then these other 3 tumors that I've mentioned, to think about those as well. I'm not going into the endometrial stromal because that's a different discussion, low grade and high grade, and all of the molecular profiles thereof. That's another fascinating discussion. But just for PCOMA, you're absolutely right. This is not the usual morphology for PCOMA. This is unusual, but that's the reason I'm showing it, because it's unusual. And the first speaker, I think, was Dina, I may be wrong, who suggested PCOMA. So spot on. Any other comments, questions? Charlie, do we have time for one more, or?
Yeah, can go ahead. Yes,
one more, right? Let's do it. Let's try one more. Let's see. Let's find something. 696. Some of you may find this pretty straightforward, but it's interesting, and we often get biopsies from these tumors, and I always resort to immunohistochemistry to work through them. This is a thigh mass. Sorry, I don't have an age. I have an adult male. Thigh mass 1.6 centimeters in the thigh. And you can see the epicenter is in subcutaneous fat already immediately. And I'm going to go down on high power. These cellular areas, and then these pink areas. These pink areas is mainly collagen, but I'm going to go to the cellular areas just to show you what the cytomorphology is like here. Okay, I hope this projects well for you. Okay. Some of this looks round. That's a nice mast cell, just to give you a size. It's sclerosing. There's a lot of sclerosis. And then just to move away, you can see these spindle cells with pointy nuclei little discernible nucleoli. Okay. And here, this is probably a nice part of a fascicle all the way down, a nice fascicle here. Probably more typical morphology here as well. Elongated, spindled, pointy nuclei, elongated cytoplasm. I'm going to show you some of the periphery as well. Let's see if we can. You can see some of these cells right at the edge of the fat invading into the fat cells. Yeah. Okay, so here's a nice fascicle, spindle cells. Any thoughts? Again, 1.6 centimeters, thigh mass, subcutaneous fat, adult male.
Dr. Cooper?
Yes, sir.
I would argue that, in my opinion, one of the single best features for this lesion, which I assume to be a desmoid tumor or a fibromatosis, is the perivascular edema.
Okay. Let's go and find some for you, Dr. Who, Tom Who, that's Tom Who. Yeah, is this enough for your perivascular edema?
For me, honestly, yes. It's the little delicate bubbles that kind of surround most of these vessels.
Okay. Okay. So the reason I put this on, because I was looking for something that we had a few minutes and Charlie has given us some time, is that you're spot on. This is a fibromatosis, but even though we have pretty good morphology on this excision, which is fairly straightforward, on biopsies, we always resort to the immunohistochemical panel in order to delineate that these are in fact fibromatosis. And the key, you may get some actin. Typically Desmond's negative, but you could get some focal Desmond as well. And those two would help. And beta-catenin, of course, is the nail on the head, because you're looking for nuclear beta-catenin, which is very focal and very patchy. Now, the reason I put this in is because we often get needle core biopsies from these. And sometimes, like Dr. Who mentioned, you get this edema around vessels. You can get tumors that have a nodular fasciitis appearance as well. And they can have hyalinizing stroma, plump nuclei, and edema as well. So that's the big differential. And in fact, we're dealing with one that has that kind of morphology. And we want to, confirm with, in fact, it's beta-catenin positive as well. But because of the morphology looking very much like NF, nodular fasciitis, we want to confirm by molecular means whether it is in fact a fibromatosis or whether it's in fact a nodular fasciitis. Nodular fasciitis, as you know, large subset of them carry the USP6 gene rearrangement. So if you have fish, that's useful. If it's positive, then it's good. You can make confirmatory diagnosis of nodular fasciitis. If it's negative, does not rule it out. Go for history, go for location, size. This is 1.6 centimeters. This is like Dr. Tom Who mentioned, is a classic fibromatosis. I would not be concerned about nodular fasciitis here. But I brought that in just to have that conversation, that in needle core biopsies, I always look here, you even have a little bit of extravasation of blood. And on the other side, I said ignore it, but you even have some mononuclear cells, which, as you know, you can get in nodular fasciitis as well. So morphology does overlap, particularly in needle core biopsies. So always use your immunohistochemistry to help you that, and clinically looking at the size. Typically, nodular fasciitis is not more than 3 centimeters, and when you cut them out, they should not recur. So just as a differential in that respect. Any comments, questions? If there's nothing, Charlie, I want to thank you all.
We just have one in the Q&A box. An attendee asked, would you have considered an epithelioid sarcoma, or is that far-fetched?
Right. That's So the cytomorphology, I think, would be not in keeping with the epithelioid sarcoma. But if you did worry about it, and if you do, as I do, epithelial markers, then that should help you in that regard as well. CD34 should help you. And of course, if you have INI1, that's the ultimate way to rule out epithelioid sarcoma. The reason I'm not thinking it's far-fetched is because you can get spindling, you can get spindle cells in epithelioid sarcomas as well. So if you do think about it, then it's quite simple to rule out. If you have INI1, that's pretty much sufficient. Keratin, CD34. CD34 is only positive in about 60%, but you can and should rule it out. I never like to think anything is far-fetched, and if my fellows or residents mention something, I always add an immunohistochemical to prove or disprove that. Unless it's really truly far-fetched, I would ignore it, but otherwise I would not. And if you thought of that, I would say just do the markers, just do the markers. This was a resection, it was proven on biopsy, so we did not do any stains, but I kept it in and put it on this set just for conversation, because not everything is rare. These are much more common, and these occur in the thigh. And I use the term desmoid type fibromatosis. That's my WHO terminology. So good question. It's not far-fetched. I want to thank all the participants. Next time, hopefully we can have better communication with my side of it. I can get my computer sorted out. And Charlie, it's going to be the same time on March 12th, correct?
Yes, I believe that's correct.
Okay, and there's no restrictions. You can share the registration with anybody and join in, and feel free to ask questions and interact. Okay.
Brilliant.
Thank you, everybody. Thank you.